morning. Welcome to the Java Cafe, Java fam.
Good morning, everybody. Good morning, everybody. Good morning. Okay, so I see that there is an issue with my camera. Let me get that. And there. All right, there we go. We're back. All right. We did some stuff in the studio yesterday. So welcome to the Java Cafe, everybody. Today is Wednesday, October 16th, 2024. And we are here with Dr. Thea James, who is a pioneering trailblazer in the place of medicine, emergency medicine, health equity, and just keeping us healthy in many marginalized communities. And so her time is short with us this morning, but I wanted to get her to come in and chat with us about the Health Equity Accelerator. And so she is no stranger to the Java Cafe at all. And so I would like to welcome Dr. James again to the Java Cafe. Good morning and good to see you in the room as usual. How are you doing?
I'm doing well, Jimmy. Good morning. Thank you so much for having me. I'm honored. Sorry, there's a
Dr. James, you don't have to say anything about tech because you see my camera went out and I don't know what happened here. So we're fine. I think it's just so important. And thank you for coming in to share the information about health equity today. And so let me ask, as I always do with guests of your caliber, you move in spaces that, you know, your awareness of disparities, your awareness of the lack of just free forming health equity sometimes, you know, is interesting for us. So I have to ask how you're doing and just check in on you with all due respect as Thea.
Oh, I'm doing well. I'm doing well, Jimmy. I mean, I'm, as long as I'm able to be in this space and be able to do the work that's meaningful to us, I mean, I'm just fortunate to be able to be in a job where everybody's rowing in the same direction.
Yep.
Everybody's intentionality is the same, and people are bold and innovative and not afraid, to break things.
Okay. Breaking things is a beautiful thing, especially when you're talking about breaking down barriers. And
That's
one
right.
of the things that, along with just your ascension in leadership in medicine, with you in that ascension is always the concept of health equity. And so we have the Health Equity Accelerator that I believe it already dropped and we're sort of catching up. But if you could tell us a little bit about the accelerator, its mission and goals, and then I just have a few questions because, this is a space that the Java Cafe moves in since 2020. And I just think it's important that we keep the audience up to date with the work that is going on and also how they can take advantage and also participate and support the work that's going on. And so tell us about the Health Accelerator 24.
Okay, so the Health Equity Accelerator came to be in 2021, which is when it launched. And so it all came about as a result of what was going on. You remember in 2020 with George Floyd and there was so much unrest in the country. And there were multiple different across sectors, organizations, companies, all kinds of people across sectors were coming out with commitment to equity statements is what I call them. Everybody was making a commitment to equity. And but here, our leaders, our CEO at the time and our COO, who is presently the CEO, they said that we weren't going to do that. They said BMC is not going to do that because, we've been in this game for a while. We've recognized that our patients have gaps. We've been innovative in creating all these various different programs. But what got their attention and made them decide that we were not going to do that was when they looked at the health data for Boston, and they said no matter what we do, these data don't change. Like data for prostate cancer, breast cancer, diabetes, all these various different things had not changed for decades. You know, it wasn't just a new thing. It was like for decades. And so they decided that we were going to instead look inside our own house. And we were going to take a look at where we ourselves might have disparities and where we may be, you know, unintentionally complicit in driving disparities. So let's just look inside. And when they looked inside, they looked across the entire enterprise. You know, they looked at inpatient, outpatient, they looked at research, education, they looked at human resources, even public safety, to see where there were disparity gaps. And we found them. Absolutely, we found them. And so they decided that they divided us up into 6 work groups, all led by executive sponsorship. And we had to identify which disparities that we were going to work on closing over the next 12 to 24 months. There was a great deal of accountability involved in it. You know, we depending upon which work groups you were in, you met anywhere from 1 to 3 times a week. And then once a month, we had a 2-hour roundtable. And we also had to report out, you know, on these big Zooms. And so, and you know, our CEO is a very strategy oriented person and a very accountability oriented person. And so we launched these, the areas that we found the greatest disparities in were things like cancer, chronic diseases like diabetes, hypertension, behavioral health, infectious diseases, and maternal health. And so the first one we did was maternal health. We had already done infectious disease through COVID, but we have used a model to just cut to the chase here. We have used a very specific model that I would say was demonstrated by the maternal health people, the OBGYN doctors. And I'll explain what that is. You know, everyone knows that Black women are, you know, far more likely to actually experience bad outcomes, you know, during pregnancy than white women. And when we looked at our data, the OBGYN department found the exact same thing was happening here at BMC. And specifically, Black women were having bleeding after pregnancy or postpartum hemorrhage at nearly twice the rate of white women. And this model that they used is, you know, generally, just to set the stage here, most people look at data like that for women like that, and they go, you know, what else is new? You know, of course, you would expect that. And they accept it as a natural order of things, and they don't interrogate it. They just accept it. And if they do try to do something, they'll look at data like this, and then they go in a room and come up with some solutions, which to me is interesting. Like, I want to know how you you come up with a plan about people who you really don't know. You don't know their lives. You don't have the lived experience. You know, you're just coming up with things or reasons that you think this is happening, and you come up with solutions without their input. So the first thing they did was interrogate the data back to root cause. So they saw that this was happening almost twice as much in Black women. And then they saw it was mostly associated with hypertension in pregnancy. And for that diagnosis, that's called preeclampsia. The treatment is to deliver the baby at that later stage in pregnancy. And they also saw in the data that doctors were taking twice as long to make that decision in Black women. And what they did was something very logical and very simple. They just standardized the decision-making process. You had to make the decision in a certain amount of time. And guess what? The gap closed right up. And they call that decision to incision. In fact, there was no standard for urgent, non-planned C-sections in that field, in OBGYN. It just didn't exist. And so by them doing this and having these dramatic gap closures, I mean, it went from 90 minutes, making a decision in Black women, from 90 minutes to 80 minutes. No, 90 minutes to 50 minutes. And for Latinas, it went from 88 minutes to 40 some minutes. And so, and not only that, these scores that you they're called APGAR scores, where you determine how babies have managed, how they have come through the actual delivery, and
Mhm.
also how they're doing 5 minutes after being born. Those scores even improved. And so it helped the moms and the babies. And so they immediately published on that, because that's a relatively like straightforward, logical decision that led to dramatic results. And since it didn't exist anywhere, it meant a lot, for them to be able to get that out there, because it would translate to helping so many other people, across the country. So that's just like one example. And the second part of that story is once you interrogate back to the root cause, they ask the subjects of the data to interpret the data. The patients ask them, and also have them partner with you with the solutions, and it works.
Dr. James, you used the term logical.
Yeah.
And, sometimes with all due to you and others that are committed, sometimes those in A&F and administration and finance kind of look at the bottom dollar.
Yeah.
And so with the patients being centered in this equitable space, I just find it remarkable, one, for a institution that is like well known. And let me just ask, just because I used to work in medicine, is this now going to set a national protocol? When
Well,
you said
for that particular
for the OBGYN, yes,
yeah, for sure,
around the
sure.
eclampsia piece.
Yeah, it's out there. I'm happy to send you the article.
Please,
Happy to send it to you. Yes,
please
definitely.
do, because that maternal morbidity, if I describe it right, where the disparity is with our women who having worse outcomes, to cite that, Dr. James, I'm just getting this in real time. There is some, and we want to frame this properly. I think I've discussed it with you. We don't say mistrust of the medical system, because that puts the ownership on the patient. I forgot the term that we said, but my point is that there are people in the healthcare industry that are pushing and doing what you're doing. And so to hear the logic informing away from the bottom line, the continuity of care for patients is just remarkable. If I can ask, as you see, I have on my pink shirt for October Breast Cancer Awareness Month. You did, one of the areas that you looked at was cancer. Are there any updates in either, on where there's room for improvement, or where you can cite improvement with screening? We know post-COVID. Yeah, go ahead, Dr. James. I'll shut up. You know where I'm going.
No,
go ahead.
no. I was going to say you're absolutely right. So as I was saying that, we launched these. We call them clinical verticals. We launched them one at a time, and cancer was the most recent one. We just launched it this year. And what I can tell you overall, whether we're talking about cancer or the chronic conditions like diabetes and things and hypertension, is one of the foundational problems is that women of color or people of color are diagnosed at a later time than white people.
Yep.
Black and brown people are diagnosed later. And the interesting thing, by the way, in the maternal health thing, we also use and then I'll get back to your question, blood pressure monitors, for women. And a lot of people start using those closer to the time where hypertension in pregnancy or preeclampsia presents itself. But we start at 20 weeks. And by doing that, one of the things we learned is that we diagnosed a lot of people with basic essential hypertension. And that had nothing really to do with pregnancy. They had it before, but it was undiagnosed, unknown.
Which puts them into preeclampsia or eclampsia. In eclampsia is the hypertension during pregnancy, right?
So no, so eclampsia is a whole nother thing.
Okay.
That's a whole nother thing where it's a much more serious state. It's beyond preeclampsia. It could be like preeclampsia, untreated, for example, or unknown or whatever, but it can be fatal. but it is a much more serious situation than preeclampsia is. But preeclampsia is just hypertension, in pregnancy.
Okay, got you.
Yeah,
Got you. Okay.
but the one thing we found out across the board is that black people just get diagnosed later, than white people do. And so our when we launched this, one of the intentionalities of that was to like screen more people and screen them early. And what I can tell you is that I just got an email 2 weeks ago where they had exceeded the corporate goals, in just a few months. And in the beginning, there were some issues with capacity. And the next thing I know, they've solved that problem and actually exceeded the corporate goals. And so, they've screened, I guess over I think it was over 1,000 women, and maybe more, quite frankly, because there's some numbers in there. There's like some 900 numbers and some 1,000 numbers and that type of thing. But long story short is the same model that they use for maternal health. They use a very similar thing for diabetes, that also closed some gaps. And they've done the exact same thing for closing screening gaps in cancer. So these are actually I call these proofs of concept. These are proofs of concept. These are things that can be done.
The thing is, in the medical industry, and at some point I would love to check in with you maybe later about, sort of the community safety, VIAP and things like that. But, there's this notion that things be data driven.
Right.
And oftentimes, as you said, the data goes in, there's a conversation and, no real outcome and change. Today, you talked about BMC taking a logical approach. Let's be 100. When you said that you exceeded corporate goals, we talked about A&F, administration and finance. There's that corporate end of things. But even in that, to exceed what corporate said and centering the patients, there's logical data that just says that, and it's just the right thing to do. And
it's not hard to do. You have to have intentionality to do it.
The medical will, we use this term, the political will, you have to have the medical industry will to do this. And so, Dr. James, I know your time. We got 2 minutes with you. Let me ask about the intentionality of influence. Not only a protocol is set within GBYN that can hopefully inform, as Naraki said, not a hospital in Massachusetts, but had 3 Black pregnant patients die in 3 years, all had to have C-sections. And to your reference point, medical term, they bled out, with all honoring, them not being with us anymore. Do you think that this has the influence to it? I don't know why I'm in this space with A&F today, but the logic surpassing, you talk about breaking things, surpassing the glass ceiling of corporate. Let's be 100. You need the money to make things run. You got to pay people. You got to pay for space. You got to, all of that. But do you see an influence in health equity policy across the nation based on what your data is showing?
I do, Jimmy, but I'll tell you this, I feel like the dominant narrative, and I always talk about the dominant narrative, but, the dominant narrative I always say is, from people's perspective about why it's so predictable who is going to do worse no matter what you measure. You always know Black people are going to do worse. And then, Latinos and on down the line, people think because they don't work hard enough, they're not smart enough, and they make poor decisions. But, what people are really missing is this. And I'll give a perfect example of economic mobility. And I'm talking about the F&A thing that you're talking about. So, you think about people, they expect people to be poor and that type of thing. But imagine if people, if you connect people to capital, for example, okay? If you connect people to economic opportunity, you connect people to better health. But if you connect people to economic mobility, for example, and by the way, these inequities are rooted in many things, with economics in many ways being at the root, and, all the structural barriers and racist barriers that prevent that's caused that situation. But people don't see that when these patients, if they have capital, I don't want to use it. I'm using the capital thing, but I don't want that
Wealth.
to get
Would
separated
wealth be a
from
good
clinical.
substitute? Okay.
Yeah, but
Okay, got you.
I'll give you two examples. For example, so and this answers right to the question that you posed. So back in 2019, Medicaid was changing their reimbursement model for us from fee for service,
Mhm.
like every time a person comes in, even if they come in 25 times a year, you get paid for it, right? So they were changing from that to value-based care, like you being accountable for every time this person comes in. So you weren't going to get paid for people coming in 25 times a year. That means that you had to understand what was driving them coming in 25 times a year. So what we had to do was to find out, who is driving the costs and why are they driving it. And we found that only 2% of our population was responsible for 40% of the cost. And the one unique thing about these 2% people, there are three unique things, but one of them majorly was most of them were housing insecure or homeless. And they also had some substance use disorder or mental illness or mental health issues. And so, and if you looked at them on a y-axis, their utilization of the hospital, of the ER and being admitted was crazy. It was like tall flames on a graph.
Mm.
But when we connected them with housing and with the kind of whatever services that they needed to stabilize them, they became stable. They were barely a blip on the radar after that. And the total cost of care significantly reduced. So it's even a better business model. And by the way, once they got housed, everything fell into place. Their healthcare their health outcomes got better. Everything got better. And so I feel the same thing about, and now I can go to connecting people to things that enable them to have economic opportunities, because when people are in a mode of survival, when we are presenting, it's about creating and capturing value for people. When we present to them to, eat healthy, go find healthy food, um, um, go find healthy food. I'm sorry, I just got distracted. Somebody put something on my desk.
Because Dr.
Somebody
James,
just put something on my desk. But
I don't want to get in trouble because we're over your time, and I don't want Trina.
I know, but
Yes,
just give me
yes,
1
take
second.
your time. Yep.
So when you present, come to all of your medical appointments, buy your prescriptions, take your medication, exercise. When you present that as a value to people who are in survival mode, that is of no value to them. But when you present something to them like housing or something that will stabilize your financial situation, like living wage employment or whatever, that they will engage with, and everything else falls into place. And by the way, once their financial situation, is stable, they become consumers who contribute to the aggregate economy that positively impacts the GDP. Everybody wins. They come off of whatever carve outs that the government carves out, to fill gaps they have, but you can eliminate the gaps they have, and everybody wins. But the dominant narrative is so powerful that when we look at folks, who don't do well, or their health outcomes are not well, people don't recognize that they are human like everybody else, and they're making rational decisions to prioritize survival over health. It's a rational decision. Anybody would make that decision in that position.
Without recognizing and being so distracted by the survival, with missing the point that you can barely survive, not even talking about the point of thriving, because you need to be healthy to do so. So Dr. James, I know you can come back anytime you want, because I want to be gracious to your time, and we're 5 minutes over.
Can I
And
just,
so
Jimmy, we should bring people back on my team too, like those ones who are like doing this actual
I
work.
would love to. I
Yeah.
would love to. And so I'll connect with Trina, and I know someone else from your staff made sure this happened today.
Okay.
But please keep me informed, because it is crucial. And you know, as we're going into the holidays at some point too, maybe checking in around an update on COVID, flu,
Absolutely.
RSV, and
Oh
all of
yeah.
that as well. And
Oh
so, you
yeah.
know,
Oh
Dr.
yeah.
James, I appreciate you. And it was good seeing you in community the other night as we were talking about an important perspective, the
That's
mental
right.
part of our health.
That's right.
And so
That's right. I mean, Jimmy, honestly, I can think of 2 or 3 people in all those areas that, would be great on the show. The cancer people, the mental health people, all of them, they're actually doing this work with these data, so and they who creating these proofs of concept. So anytime, I mean, I'm so grateful for any opportunity that I have to, share with you and share with the listeners, um, and they would love these folks as well. I can assure you that.
we can definitely make it happen, Dr. James. And that last piece, as you get ready to go, is, that dominant narrative. That's one of the reasons this platform exists, changing the narrative, telling our stories. And I appreciate you, Dr. James.
I
And we'll
appreciate you
make the
too, Jimmy.
connection, and we'll go from there.
Thank you so much.
Thank you.
Appreciate you. Have a great day.
Thank you. You as well.
Okay.
Folks,
Bye
I
bye.
hope you were inspired to do, look at your own healthcare. We haven't been too deep in it lately, but it's a pillar of the Java Cafe health equity. It's a pillar when we talk mental wellness and addressing mental illness. And so I just want to check a couple of comments before we get ready to wrap up this morning. Just want to acknowledge Miss Teresa. Thank you so much for my breast cancer awareness shirt. And good to see folks in the room. Anissa, Mama Java, Michelle D. Smith, Naraki, good morning, beautiful. Sharon Cornelius, good morning. Good to see you in the room. Sister Debbie, and also Sister Soraya. Brother Vaughn is in the room as well. Thank you all for being with us this morning. Folks over on Instagram, Liz O'Connor, good to see you in the room. Nikki and a few others. D-Mark was in as I owe D-Mark some working out a couple of journal entries. And so with that being said, I'm going to get off of here. Tomorrow morning, a shot of Java. There's some things I need to just get out my system and share with you in reference into some of the lackadaisicalness of the Office of Community Safety. Reiterating the importance of voting no on question 5 and a few other things. And so we will have a shot of Java tomorrow. That is the time where we check in with the Java family one-on-one. And once again, I want to thank Nia Grace, who came yesterday and gave us some information about question 5, shared some of her story as well. And so be sure to go watch that episode if you did not, and understand the importance of tipping our hospitality staff, barbers, waiters, servers. I'm just going to leave that there. So I'm going to get off of here, folks, and we will be back tomorrow morning at 10 a.m., probably back to the old setup. I kind of like, if you all can see the way we set up things here, it looks kind of good. So Michelle, Black Java tomorrow. I actually have a call shortly. I am working on the best construct, or what's the word? Layout at Southline, to where I'm not setting up, breaking down, not interfering with their day-to-day and their daytime. I'd be there in the morning, but we kind of loud, and they got a whole office. And so we're actually meeting today about that. So right now, there is no, I can not just say right now, there is no Black Java planned in person for tomorrow. Michelle, thank you for asking that, because I really wasn't going to put any information out about that, because we really didn't announce it. But no Black Java tomorrow. We will make up for it. I still owe you the broadcast, Brother Mike Dees and Dart. During this segment, Brother Dart got very excited, and the camera went out. And so I have to fix that edit, but we need to cast that broadcast as well. And Michelle, let me know. I will let you. Well, I'm old school when it comes to setup. I'll be having the brothers fuss at me, whatever. I'm just old school. Brothers are going to do the setting up. So anyway, let me get off here. An hour for UCB members. UCB members, I'm so excited to be with you this Saturday at Hibernian Hall at 1 p.m. for UC Talks. I am hosting the event. We have some great speakers, folks like, and I want to make sure I get all the names, Sheena Collier, Thaddeus Miles, Jaron Chang, Eric Leslie, a couple of other folks that are going to speak at the UC Talks. And so that's taking place this Saturday at 1 p.m. at Hibernian Hall. We look forward to seeing UCB members and others there. Again, shout out to everybody that was listening on Instagram and also Twitter. Thank you for being a part of the conversation. Also, if you do not follow me on Instagram, please go and do so. I'm 20 followers away from another milestone. We are growing. We have grown over 3,000 followers in a year over on Instagram. And then YouTube. If you don't subscribe to YouTube, go over there and subscribe as well. I'm about 500 away from being able to do some things over there. And so there's some changes and some things coming. You're always, rebranding and staying relevant. We're always going to be relevant because community is relevant and at the center of this platform. But there's some, changes and things coming to just improve and enhance and get us to the next dimension, not the next level, but the next dimension. And so Java fam, we got some great things coming. Don't forget March 22nd, 2025 is the Java Gala. There will be sponsorship opportunities for individuals, entities, and organizations. In the very, very near future, there's one rate if you get in for early sponsor. And then there's another rate after a certain date if you want to be a sponsor and be visible and demonstrate your support for the Java Cafe. And this is more corporations. I see y'all in every day with the support there. So, all right, that's it for me. I'm off of here. Tomorrow morning, 10 a.m., a shot of Java, and we will see you then. UCB members, you get your hour today. You probably only get a half an hour tomorrow. So, but you can make it up on Saturday and go to the UC Talks. So that being said, have a great afternoon, everyone. And we'll see you tomorrow morning at 10 a.m.